Differentiation between true gestational sac and pseudosac is very important, both from clinical point of view and for exam point of view, both for MRCOG and FCPS. We'll discuss this in detail. We will discuss sonographic features of both and what is the pathophysiology of pseudosac and true gestational sac. What is the difference between double decidual sign and single decidual ring? And what is the role of color Doppler in differentiation of both? And what are the clinical implications of misdiagnosis? So as you can see that this is a true gestational sac. The sac which is formed in a intrauterine pregnancy, which is the earliest sign of an intrauterine pregnancy. So this sac is actually not centric. It's a bit away from the center. That's why we call it as eccentric in location. So it is not exactly in the center of the uterine cavity. It is eccentric, away from the center. And it has double decidual ring. The ring is thickened, having two layers. This is the outer layer, and this one is the inner layer. And it is embedded. It doesn't flow, or it isn't mobile with pressure of the probe. So it is the first evidence on ultrasonography of an intrauterine pregnancy. Location is eccentric, as we discussed. It is embedded and not floating. It shows double decidual sac sign, that is two concentric rings surrounding the sac. This was an inner ring, and there is the outer ring. Inner ring is the decidua capsularis, which surrounds the chorion, and the outer ring is the decidua parietalis, which is towards the uterine cavity. So this is the decidua parietalis, and this one is the decidua capsularis. Now coming towards the pseudosac. As this picture is showing, it is almost in the center of the uterine cavity, and it's not circular. Its ring is thin, outer ring is thin. It doesn't have two layers, and it just looks like a fluid-filled cavity. It's seen in almost 20% of ectopic pregnancies. Why it is formed? It is formed because of hormonal stimulation of the endometrium. We can think like that when the uterus perceives that uh, implanted egg, fertilized egg is going to be implanted there. So the uterus or endometrium prepares itself for the implantation. However, the implantation occurs somewhere else other than the uterine cavity. So just a residual reaction occurs in the uterus. And it is actually small amount of blood or secretions in the endometrial cavity. It can sometimes mimic a two gestational sac, and so it can lead to confusion in the management. It is centrally located within the uterine cavity. That is, it fills the space between the endometrial layers. It's often oval or irregular in shape, and the edges can be pointed. It just follows the shape of the cavity. Actually, the it, the filling in the uterine cavity means that the space between the anterior endometrial lining and the posterior endometrial lining, it fills the space there. So it's not, the sac is not embedded there, it is just a collection of fluid and takes the shape of the cavity. So the difference is, as we discussed, the true gestational sac is eccentric and it is buried in the endometrium. Our pseudosac is central and within the cavity line. True sac has double layers and it has single ring. And if the yolk sac is present in the true gestational sac, then it is confirmative of intrauterine pregnancy. In pseudosac, obviously, yolk sac will be absent. And the shape is usually round and regular in cases of true gestational sac. And in pseudosac, it is oval or follows the shape of the uterine cavity. Then to differentiate between the two, we can do color Doppler. In two gestational sac, there will be flow around the ring, which is called as peritrophoblastic flow or ring of fire appearance. The flow is high velocity. It means that a ring of fire will appear around the gestational sac. It is of high velocity and low resistance. Resistance is low because of trophoblastic invasion. And in pseudosac, it is the flow is absent, so there's no ring of fire. Or sometimes flow may be seen in the surrounding endometrium, but it doesn't specifically surrounds the area of the fluid collection. So this is a ring of fire in cases of a true gestational sac. You can see here that it's surrounding the the residual ring. So this was regarding ultrasonographic features of both true sac and gestational sac and the pseudosac. We know that we need to differentiate it so that we can manage the pregnancy or we can decide whether it is more likely to be intrauterine pregnancy or the ectopic pregnancy. Beta HCG also has a role in deciding our management. So if beta HCG levels are around 1500 to 2000 international units per liter, on vaginal scan on TVS, a true sac should be visualized. However, in cases when HCG is more than 2000 and no sac is visualized, or there is central fluid collection, meaning there is pseudosac, there is high suspicion of ectopic pregnancy. However, we can't decide on a single ultrasonographic findings or beta HCG findings. We do serial HCG. You know that in intrauterine pregnancy, the rise should be almost double in 2 days or 48 hours. In ectopic pregnancy, when there's pseudosac present or not present, then the levels are usually suboptimally rising or may plateau. So the important points to note are that never diagnose pseudosac only on B mode without Doppler. And whenever there's double decidual sign seen, even if yolk sac is not present, then it has sensitivity of 98%, specificity of 98% for intrauterine pregnancy. And if yolk sac is visualized, then it is 100% confirmatory for intrauterine pregnancy. Whenever there is central fluid and single ring, meaning pseudosac, then search adnexa carefully for signs of ectopic pregnancy. And if unsure, then scan needs to be repeated in 48 hours or correlate with beta HCG findings. And avoid methotrexate if there's any doubt of viability, because it will damage the viable intrauterine pregnancy. So let's do some brainstorming based on what we discussed. A 32-year-old woman presents at 6 weeks of gestation with mild vaginal spotting. She is hemodynamically stable. TVS shows eccentric gestational sac measuring 10 mm within the endometrium and showing double decidual sac sign. So all the signs are pointing towards true gestational sac. We know that there is eccentric sac, double decidual sign, and a visible yolk sac. So it is obviously intrauterine pregnancy. However, no fetal pole is currently visible. Both adnexa appear normal. Serum beta HCG is 2500 international unit per liter. So what is the management plan? That is, we give her methotrexate, repeat scan, diagnostic laparoscopy, or immediate suction evacuation. So obviously the answer is B. That is, we will repeat scan in 7 to 14 days because earlier signs of intrauterine pregnancy has appeared and the patient has only mild vaginal spotting, which can be there in cases of viable pregnancy. So we will wait for 7 to 14 days, then we will repeat the scan. In the other case, patient is having right iliac fossa pain at 7 weeks, widely stable. PVS shows an echoic centrally located election. So it is pseudosac, most likely, surrounded by a single rim, no yolk sac or fetal pole. So the scenario is pointing more towards the ectopic pregnancy. A 25 millimeter complex mass is visualized in right nexa, no free fluid in the pouch of Douglas, and serum beta HG is 3200. So, what is likely diagnosis and appropriate management? So, it is an ectopic pregnancy, and as the patient is vitally stable and there is no free fluid, size is 25 millimeter, no FC identified, beta HG is less than 5000. So, what will we opt? We'll opt for ectopic pregnancy, it's medical management. So, this I hope that these scenarios are clear now, because sometimes in the clinical situation when you are dealing with a patient or in the exam, these kind of scenarios come when you have to decide depending upon the appearance of the sac and beta hg levels in patients other symptoms. So I hope that this difference is clear between the both types of sacs. If you have any questions, you can ask in the comment section. Thank you.